Welcome everyone to this episode of Office Hours, and it's actually our last one of the year, and I can't believe the year has gone by so quickly. But here we are, December 2025. And as usual, I'm your host, Stuart Newsom. Today's conversation is titled An Inside Look at a Prior Auth Turnaround with AI-Enabled Services. So we'll be talking about how health systems are rethinking prior authorization workflows using a combination of centralized operations as well as AI-enabled automation, as well as tech-enabled services. So we'll dive a little deep into that. And all of this is to reduce the burden, improve efficiency, and support scalability. And I'm really excited to be joined today by Rayne Premo. She's the Quality and Prior Authorization Manager at Iowa Specialty Hospital. Rayne, welcome aboard. It's glad to see you again. How you doing?
Doing good. Thank you for having me. Excited to share what I've learned over the last couple of years.
Awesome. You've been a great partner, and that's what we truly look at this. Our clients are our partners, and Rayne, you've been one of the best, and we really appreciate how you've helped us, improve our services as well as our solutions. So happy. I'm really looking forward to diving in today.
All
Um,
right.
for today's discussion, just kind of give you a little snippet of what we're going to talk about because I always like to do that. I like to tell people what we're going to say in the beginning. But we're going to be exploring a few key themes throughout this episode, and some themes that many organizations can probably resonate with and what they're grappling with right now. So we'll talk about what prior authorization looks like inside a multi-service rural health environment, which Rayne is a part of, some of the operational and staffing challenges that everyone shares that tend to surface in those environments as well, and how centralizing prior auth work can change both efficiency and staff experience. So we'll also dig in how AI-enabled services as well as automation fit into that world, in the real world, that is, not as a replacement for teams, but as a way to reduce that administrative work that so many teams are facing. And then finally, we're going to look ahead at how organizations think about expanding prior auth support across additional service lines, preparing for what's next. Because 2026, there are going to be some changes. And
Big
as
ones.
always, yeah, exactly. So we may dive into that as well, kind of what those changes will be. But just as a reminder, we'll leave time at the end for audience questions. And I always like to tell everyone to submit comments. We're talking here, but if you have some insights that you want to share as well on this subject, please put them in the comments. I'll be sure to read those as well. In addition to answering your questions, if we can answer them or get to them all, if time allows. So with that, Rayne, you ready to dive in?
Absolutely. Let's get started.
All right. Well, I guess right out the bat, for attendees who may not be familiar with Iowa Specialty Hospital, can you kind of describe what the facility is all about and the patient population and the services that you support?
Sure. So we refer to ourselves as Iowa Specialty Hospitals and Clinics. We are a critical access organization. We have two critical access hospitals, Belmont and Clarion. We are located in the same county. So we're kind of one of those rare situations where we get to have two critical access hospitals in a single county because we are right at that line of being 15 miles apart. So um, we joined in working together about 12, 15 years ago. And since then, we also now have about 13 clinics that are part of our system. What we specialize in is family practice medicine is primarily our clinics, but we also have at our Clarion facility, we are ortho based. So a lot of knees, hips, shoulders, those types of surgeries. In addition to that is our home base for our OBGYN work. We are sitting at this morning, I believe it was 678 babies.
Mhm.
Potentially, we're shooting for 701 by 1/1 of 26. That's a personal record for us. Probably one of the largest critical access delivery facilities in the state. And then our other critical access hospital, Belmont, primarily does bariatric surgeries. We also have our spine surgeon out of that facility as well. So we keep both our floors and our surgical suites very, very busy with that. And with those types of surgical procedures, our ancillary departments support that. So we have a full scope of radiology and imaging, laboratory services, rehab, cardiopulmonary sleep, all of those. And then again, 13 different clinics that have mental health services in addition to regular family practice and specialties supporting the surgery world. So lots of things going on all the time.
Yeah, I'd say that's very busy. And if my math's right, that's 33 more babies before the end of the year. So
Hmm.
that'd be average,
Uh,
what, about 215 a week, 210 a week, whatever. So that's,
uh, Sometimes it feels like it's 10 a day, but yeah,
oh wow. Wow.
we got 5 days. I think they're going to pull it off, but we'll
Yeah,
see
yeah.
what the weekend holds for us. I mean, I don't think we have any snow coming, so it might be a quiet weekend. Who knows?
That's awesome. That's
Somebody's
awesome.
going to
Well,
probably come around the corner because I said the Q word. So, if I'm off in the middle of the webinar, I apologize.
no, I'm sorry. Not my fault. I'm sorry.
I
Well,
used it.
with all that said, as busy as you are, there's a lot of room for what we're talking about today, because I'm sure
For
there's
sure.
a lot of prior authorization that's needed in those environments, and it's just huge. Before centralizing prior authorization, which I know is what you've known for there, what kinds of challenges were you seeing across
Hmm.
departments, whether operational, staffing, or tied to any payer response times? What was the day in the life of Iowa, especially regarding prior auth before it
Yeah, for
became
sure.
law?
Um, I think if you weren't involved, you didn't fully understand how painful it really was, right? On when I stepped into the role of just looking at the project that we had with Infinex of having some additional support through your guys' system, walking into that, looking at ancillary departments, our imaging department was actually looking to hire their third medical secretary because one of them spent literally all 40 of their working hours working on prior authorization.
Mm,
That delays care. That means patients are not getting scheduled because they can't do that until they get those. And it was a very manual process. Um, so a lot of time spent on the phone, a lot of time spent digging through the portals. From a surgical standpoint, those actually were, in addition to our ortho and our bariatrics and our spines, we also do a full gamut of OBGYN healthcare and general surgery. So we had two full-time people dedicated to doing prior authorizations for just 6 surgeons. The rest of our surgeries were being performed by their clinic nurses, and they were spending anywhere from 10 to 15 hours a work week doing prior authorizations.
mm,
Again, you can't move forward with anything scheduled until you have that prior authorization. So that was impacting their day-to-day workflows of deciding, do I take the time to be on the phone to push the surgery through, or do I work with the patient who's standing in front of me? So there was just a lot of that. And then on top of that, you factor in just the burden of pulling clinicals, faxing them in, the follow-up of it, denials, and then having to schedule their provider to do a peer-to-peer. There was just a lot of that. And when we really looked into it, um, that was just on the front end, right? Then you go to the backside, and our denials and our write-offs were post-procedure pretty significant, especially in some of those higher volume, higher paid areas like MRI. So it was definitely impacting on both the front and the back. We just nobody really knew what to do with it. They just kind of accepted it as part of the status quo.
wow. Yeah. So, and it's, I mean, we hear that as well. I mean, it's just not enough staff. There's just an overwhelming amount of work to be done, which takes the fun out of work, or
Hmm.
sometimes the meaning out of work. It can be detrimental to the psyche of the staff in a lot of ways. It's like a hamster wheel that never ends. Um, and and so I understand also that when you bring some relief in, maybe it's additional human capital for human resources, whether it's outsourcing, whether it's using AI that we're going to discuss a little later. Sometimes that can be a threat. Many organizations struggle with staff fear or resistance when shifting that prior auth work or offsetting it,
Hmm.
even though they're living this nightmare. For maybe I'm over exaggerating that, but yet they're still kind of like, wait a minute, they're still getting defensive about it. So what approach did you take to build trust and address those concerns and get teams aligned around a centralized model?
For sure. Think one of the things that plays a key role into is, let me give you a little background about who I am. I have been a lab leader previous to my current role for about 15 years in the lab world, around 20. And then post COVID, I moved into the quality coordinator role. So my purpose is process improvement and to really look for those places where are we doing things most efficiently? And as a person who worked in the lab for a long time, my other part of my goal has always been how can I make your job easier so that you're making our patient outcomes even better? So when I was asked with looking into the use of Infinex to just help just our surgery ladies who were doing ortho, so those two who were doing the six surgeons work, um, that was the idea. And so when I stepped in and I started looking at it, I will 100% own that we probably sabotaged that project a little bit initially before I was on board because of that fear exactly, Stuart.
Mhm.
Well, this is to replace me. This is to get rid of me. They don't want me to do this job anymore. And I never had that as my thought process. I view as, again, it's a tool and a way for us to improve. I could see that they were overwhelmed with the work. So how can we help approach it from that standpoint? So the very first thing you do is you always listen. What's your fear, guys? Like, why do you feel that way? What was said to you? How was it presented? What did they have involvement in the decision-making process? Um, did they get shared the different vendors or the approaches that we could possibly use? And I think that was probably, if we could redo it, that would be definitely something I would have done different when approaching the project, is having some options and making sure the people who do the work are there making the decisions on which one we're going to go with, right?
Mhm.
So once we kind of got some of that information and we built a rapport amongst the three of us because it was a very small group to start with, we really started to look at, well, where do you spend your time? Where's your frustrations? Why are you having to do it the way that you do? And I'm like, okay, if we do it this way, you realize you're going to have this much time back in your day. You're going to be able to do twice the amount of work and it's going to have this positive outlook for your providers. And so I think that really helped. And with us being a small critical access organization, there's a lot of ownership. I think that's always a huge piece too. You want to have the right people on the bus in the right spots.
Mhm.
For me, a big place that I drove it home for them is they felt like they could never have PTO or be sick because somebody had to do the job, right? Well, by utilizing our process that we implemented, they were able to see how they have support. There are other people who can help them do the job even when they're not there. And that's what I think really eventually turned the tides for us, was their ability to see how they were working as a team to support the overall positive outcomes of the patients, not that it was set up to be something to replace them with. I think that's your biggest hurdle. If you can help them understand that it is to support and it's a tool, not a replacement, you're going to have a good buy-in and a good outcome of it.
Right, right. And then they buy in with each other. They start supporting
Hmm.
each other in that endeavor too. So it sounds like it really starts with good leadership that you provided, which is very key to give that direction, give that assurance. And I'm sure it's not like one speech overnight, right? It probably
No.
took a long time to kind of get to where you needed to be.
And it's just having those frank conversations when things don't go right, like
Right.
being open to them expressing their concerns or their fears. And we had to develop a team mentality between us and Infinex and our team. And
Mhm.
it wasn't us against them. It wasn't your way or my way. It was what's going to be our way, what is going to work best for our patients. And that was what we really drove home. And I've shared with everybody that I work with at Infinex that our team is the best. And we call them our offshore team because they are. And we have nothing but good things to say about them. They do fabulous work. The communication, I'm not involved anymore. Like just kind of on the outskirts of it because they work as a single unit. They are there to do what they need to do together. It's not going through this hierarchy. They actually can work very closely together through the different types of communications that we have. The
And that,
portal,
that, yeah,
emails, phone calls. They just they call the person they need to on both ends. There's a
yeah,
question on the Infinex side, they reach out, and if we have a problem, we reach out.
that's amazing because that's the true KPI metric in my opinion. And it's not really a number or even a
Nope.
KPI. It's, hey, is the boss got their feet kicked up? You know,
Hmm.
not to allude that the boss has got their feet kicked up. I'm just saying
Absolutely.
they're not
But
involved. They're not
they
involved. So
should be able
that's the
to
key. That's the
empower.
key
Yep.
measure. If that happens, then you're doing something right. That's awesome. Um, So now kind of rolling into measuring, speaking of measuring,
Hmm.
we're going to roll into kind of measuring some of the impact. But once those changes were implemented, and you kind of spoke of this already, but what early indicators or outcomes helped you understand whether the new workflows and tech-enabled support that Infinix was supplying were making a measurable difference in your organization?
For sure. And I thought about this a little bit because I wanted to make sure I articulated the example well. So one of the things when we first looked at the project was where did we start, right? Like we started with surgery. In my opinion, that was probably not the right place to start. So as I was going through looking at where, again, where do you start? High volume, where you're losing your most money. For us, that was actually an imaging, MRI. There was a couple of reasons we were not having prior authorizations on file for the ones we did, but on a bigger end, there was a delay in care. So for me, the metric that I actually used in the beginning, once we got imaging fully deployed, was can I show the improvement or the reduction in how long it took you to get in and have your MRI, which is all going to feed up to my ortho people, right? Like they're going to do
Mhm.
the surgeries on whatever is found. So if you can move that along faster, you're going to do well. So I was actually able to use the metric of the number of orders coming in and the time from receipt to the time of completion. And that was a really big eye opener for my administration because
Mhm.
they were getting complaints and concerns from providers and patients and outside sources that we weren't getting people scheduled. And so then the imaging leader was getting frustrated because she felt like her team was their hands were tied because they couldn't get a prior auth, so you can't put them on the schedule. So we were able to actually take that piece out, and they have a full schedule all the time. So people are moving through as fast as we can get them in.
Wow.
And not because of prior authorization, but because of, you can only see so many people in a building and in a machine at a time.
That's right. I mean, there's 24 hours in today. Everyone has the same 24 hours, that even the machines have the same, and they have a certain time that they have to
Yep.
process their test. So, I mean, that's the thing.
We
Time.
were running at full capacity.
Wow. Yeah. That's awesome. That's amazing. And then, when we shift now to the role of AI and technology in all this process,
Hmm.
Infinix has a lot of AI agents and automations and things that we're working on really from our experience that we have with our clients is what drives that. So, and we've seen on the industry, there's a growing interest in AI enabled prior
Hmm.
authorization in particular, particularly in the area of medical necessity checks, for
Yep.
that prior authorization, not to mention the automated workflows that stem from that. So, how do you view the role of these technologies improving efficiency and documentation quality?
Yeah, first of all, I think we're behind the eight ball. Your payers have been using AI for quite a bit longer than the rest of us. And so we are having to meet the technology that has already been used against us. It's a really good way to look at it. Um, I see us using these tools going forward to improve documentation because most of us are on some sort of electronic EMR. Your documentation comes from a person, but if you can make their workflow for capturing their information as seamless as humanly possible or tech possible, then you're going to improve what you need to capture and push through the payer's AI and move it's going to happen faster because it's going to be either in the same discrete data fields or it's going to be in the language that it's using to search your documentation. What I mean by that is just use a provider's note. We're really super lucky. Our organization supports a lot of technical advancements. And so we're using um, some AI in the background that's ambient, that is capturing the conversation between me and my provider and is already pulling out pieces of that and putting it into their notes. And then on the flip side of that, because again, there's still that human component to my team. When we are getting denials, we're taking that information back and restructuring their notes so that the information we do need is in there. So, for example, let's talk about rehab therapies, right? Like we know we have to have an MRI. Great, they did that and they were able to have their first round, but now it's a recertification. So we need to have some of that functional assessment pieces in there. So we're adding that stuff into their notes so that they don't get an option to forget to add it. It's all right there. It's easy, 1, 2, 3 clicks for them, the drop down. So what we want is there. It's all on that front note that's going to be given to the payer. So it really takes the option away of the payer from denying it because they have all their pieces. So you tell us how you're going to not pay us now, and we'll come up with another way to fix that.
Yeah, exactly. So it's because it is an arms race.
Mm-hmm.
I've called that called it that many times. I've spoken about that many times. And you have to be ahead of the payers, using the same methods that
Tools
they're
that they're
using,
using against
like,
us.
yeah,
Yep.
the rules and everything. I mean, that's why, in Phoenix, we've built a lot of these capabilities, and trying to stay one step ahead of the payer is a challenge. And we're right there. We're even looking to launch an AI medical necessity, agent that can
Mm-hmm.
be kind of right there, at prior auth. Typically, when people think of medical necessity, they think of the claim side, that's going out and the claim comes back and it was the good old CO50 where it's lack of medical necessity, right? And
Yep.
so that, looking at that remittance code that comes back, then you have to go into investigation. Well, this is going to be preemptive. We're looking at this from that standpoint, and we have all the data that's available from that AI engine that's going to articulate that. So, whereas now we have a prior auth that, if it's needed, we're going to be sure that there is a determination. If the determination is needed, it's going to go ahead and process the initiation. And this is all through automation, the AI agents. This is all being facilitated without any human touch in the process. And that's the goal, because we want to make sure that we're building efficiencies for the staff, not building barriers, for the staff. And so, with that lens, or through that lens, and what you've also described too, the whole goal is, again, we don't want the staff to have any fear that they're going to be losing their jobs, but at the end of the day, they're going to, like, where has this been all my life? This is making, my life not necessarily easier, because they don't want to frame it that way, right? Because they want to make sure that, hey,
No.
I'm my money. But it definitely is, where, and it's all kind of in the background. There are many things that, for an example, here at Infinix, that we're doing things that are in the background that just make it so seamless that a lot of our
Mm-hmm.
clients don't even realize that that's happening. But they do realize that they are able to get to the high cases, high level cases much faster. They're able to process things much faster. Whether it's tech enabled, meaning that we have human capital that could be working on that in addition to the AI working together. So um, when you can wake up and not realize that this is going on, but it's for your benefit, then you've arrived as well, in my opinion.
And I think it allows you go into healthcare to help people. And I think that's, when we talk about how do you get things to align, is you have to remember that yes, it's tools and products and things, and that we're trying to get an end result, but there is a human attached to that. And if you always tie it back to this could be your mom, your brother, your sister, your
Hmm.
dad, your offspring, it helps drive that passion and purpose behind it. And so it makes it easier for us to be more open to those things and use those tools because especially in a rural community, that could be your mom, like I said, somebody that you
Yeah,
know. And if you don't get that prior auth for me, you're going to hear about it. Like they're going to know. Everybody knows my team of, I have 11 now because we also do medications. Everybody knows that they're on the prior auth team. They go to the grocery store, they're asking them, hey, can you maybe push my MRI through a little faster? And we're like, yeah, wish. That's not how it works anymore. But
right.
that's, everybody knows who you are. So they do take a lot of pride in their work. And if there is some way that we can help ensure that not only because there are a lot of payers that'll say some things don't require a prior authorization, but then they're not going to pay me when it's done because it didn't meet medical necessity. If we can pull those two pieces together before the patient's seen and the procedure's completed, we're all going to come out better on the
Right.
backside for that.
Totally agree, because it's all about community, and that's the key example. about, caring for the community and the community caring for you. So
Mm-hmm.
absolutely. Kind of talking about future state. Now, maybe this is where the wish list comes in, Rain. So,
Mm-hmm.
kind of looking ahead, are there areas such as medication prior auth, maybe even PTOT or other service lines where you see opportunities to expand or refine prior authorization support? I guess put it this way, if there was something you could change about the whole process, what would that be?
I think one of the things that everybody can agree on is if we can continue to improve the data collection at the front end for the providers, making sure that they have all the information at hand. I think there'll come a time when instead of it having to be a retro phone call or check the portal for a CPT code, we're going to be able to be in the room with the provider, having a conversation, saying, "Hey, I think I got a tear in my arm. I might need an
Mhm.
MRI." And everything's going to be happening in the background that when the provider looks at his system, it's going to be like, "Oh, yeah, you have Blue Cross Blue Shield and you're going to require 6 weeks of PT before we can even do that. Do you want to get that scheduled? I've got 3 days open." Like from a patient happiness standpoint, like I have an answer, I know when I'm going to be at, and I'm going to be doing it, and it's all done. From a provider standpoint, they don't have to follow up. They're not waiting for someone to get back to them. How are they going to remember to do those things? And all of the pieces that they need, the medical necessity, the right codes being selected the first time, are all going to happen together. And the reason I say that I think is going to happen is because all those pieces I do know are in development in
Mhm.
various capacities, whether it's through Infinix with the medical necessity piece, um, with providers working, like our EMRs working with their builders to create the capturing of orders at the same time that they're being said. All these things are happening in the research phases. It's going to eventually come together and it really will improve and streamline healthcare from that standpoint. My wish list would be for your payers to also join in on that and make it a
Amen.
group effort to do what's best for our population.
Amen. Absolutely. I couldn't agree more. Because and again, I mean, and the payers, I think, want to get it right, but also I think there's this, you know,
Well, we're in this state because we did it to ourselves, right?
right,
Like
right,
people had things that they didn't need to have because they circumvented the system and then insurance is a business. So
exactly,
now we're here we are.
exactly. Here and here we are indeed. And I think those are good insights. I do think that it's going to escalate much faster and faster. You know, being in the industry for as long as I have, and I think healthcare technology moved at a pretty slow, steady pace, but now it's really moving fast. It has ramped up quickly because of the arms race that you mentioned, that we have to be ahead of the payers, and that's the carrot. Where we're going to be and how we're going to get there. Um, so with that, that's all the questions I have for you, Rain, but we do have some audience questions that I want to
Yeah.
chime into before we close up today. Um, the first one here is for rural or resource limited organizations, what advice would you give on prioritizing which prior authorization work should be centralized or supported first?
Yeah, and kind of alluded to this before in the sense that really look at where is your high volume or your high cost. Um, and by cost doesn't necessarily have to mean financially, like claims being written off or anything like that too.
Mhm.
It could be the human resource piece. Where are you teetering on losing a staff member because they have reached their max and they can't take anymore? Is that a place where you can start to implement one of these types of processes to help improve their day and their workflow so they can get more done because we're all going to do more with less. So
Right.
for me
Right.
at Iowa Specialty, that made sense. It should have been imaging.
Hmm.
They have the highest volume, and when I looked at on the backside, we had the highest write-offs from their procedures.
Mm. Of course. How about that? Well, and then aligning with that, I mean, we have another question that has to do, it looks like it has to do with documentation, but what practical steps can organizations take to ensure clinical documentation aligns with payer expectations? You spoke about that a little bit. Improving both authorization outcomes and downstream revenue cycle performance.
Mm-hmm. One of the the offshoots that I don't think everybody realized when we centralized prior authorization that we would have was actually the improvement in documentation and how that impacted our coding department. Because we had to have it for the prior authorization documentation and we started working with those providers to make sure their notes and things were there. That kind of had a domino effect with other departments following suit. Sometimes a provider would use it for one specialty area and it was like, I really like that structure. Can you apply it to my other areas? And so we would update all the notes. And then eventually everybody saw how that was working for them. Then we applied it against the rest. And so that has helped coding. We do a lot of AI in the background with coding. And so those things were correct. So they were just moving right on through the system. There's a lot of AI processing going on fully for a claim to go out the door. We saw a reduction in how long some of those claims were getting stuck. They actually weren't. They were heading, from the time everything was completed and out the door. Sometimes we could get stuff out in within 24 hours, which was a big improvement too.
Mhm.
Um, so for us, I think that was like one of the when it aligns and it aligns well, you're going to see that improvement across the whole rev cycle. A sidebar that came for us too was we simultaneously were educating everybody else in the organization where to find our information. So we were putting our stuff consistently in the same language, in the same place, so that whether you were a nurse, a provider, or a patient, you could go and check and see where your prior authorization status was. Proved in the, like, yep, it's still at the payer, it's day 3, we know, but sorry, it is. And, like that kind of stuff. And it's a reduction in people searching for things, making phone calls, getting frustrated, leaving a sticky note to go back and look for something because they could find it as soon as they could just go into the chart and it was right
Sure.
there.
Sure. That's awesome. That's awesome. And centralizing things is key. And that's what you did, with great
Hmm.
leadership, the team that finally, worked together. Sounds like they love each other as well. So that matters as well.
We're a
So
fully remote team, so it's interesting because
yeah, that's an interesting dynamic. COVID changed
yes.
everything, but it's definitely where that's now the norm, where it's just
Hmm.
being remote. And that has its own challenges as well. So very excited that you're able to accomplish this. We're also very excited that Phoenix was on that journey with you for sure.
Stuart,
Um,
did you see that we had another question?
oh, I did not. Oh, here we go. Good eye. Okay, so here's a question is who currently checks the payer medical necessity before submitting the authorization? Your organization or Infinix? So I'll offer some clarity before Rayne answers that question because she may have a system in place as well. But our medical necessity AI is currently launching into beta.
Mhm.
This has been under development, but the word's kind of out that we have this coming because the industry is just demanding it. So Rayne's not using that particular piece of technology because it's just not available yet. But I'll let her step in, and I can be more than happy to answer more questions, offline about that if you want to reach out to me. But Rain may be able to answer that as well.
Yeah. So clearly we have not third-partied that out. I will quickly share that we did have a demo of the product that Infinix is working on. It is going to be amazing, and we're super excited about it. Um, in theory, it will go at the same time as the prior auth at some point. So again, it's, not fully built out or implemented yet. So, um, hoping to see that. For us currently, we're like any other facility. Anybody who's been in healthcare for a while knows that the responsibility of medical necessity resides with who the revenue resides with. So technically, it should be at your um, provider's level at the time of order. Also, if you've been in healthcare long enough, you know that that's
Ideally,
not what
yep.
happens. It goes to the department who is going to get the revenue, and they're playing catch up. And they also can't know what matches every time. So we are exploring different ways. We have a lot of internal human processes built around our EMRs checks, which unfortunately is really only Medicare, but we do try to apply some of that logic against our commercial payers. So short answer is about 3 different groups. The providers trying to get them to catch it in the beginning. Um, prior auth because we see the same procedures over and over again, looking for that common diagnosis. And if it's something completely different, we're sending that back to the providers. And then eventually, when the department who's going to perform it schedules it, they're also doing a check.
Awesome. Yeah. It's typically more than one person because you want to have
Hmm.
checks, rechecks, and checks and balances. Make sure you're checking the people doing the first check. There's a lot of checks in there. But
So yeah, we're super excited because it's commercial payers. That's going to be it's going to be a win.
yeah, exactly, exactly. All right, let's see. I think this is yeah, that's the same question. Looks like there was a
Hmm.
one question, but gotcha. All right. Well, I don't see any other questions. Really appreciate the questions that we had come in. And I want to thank you, Rayne, for being on. You were terrific, as always. Didn't expect anything less. But thank you for joining us today. It's always great speaking with you.
I appreciate the offer, and you guys know I like to talk, so that's not unusual.
No worries, no worries there. And also thank everyone for joining us today on this office hours. As I said earlier, this is our last one of 2025. Our next office hours will be launching January 8th, 2026. Can't believe I'm saying that out loud. But so everyone will have a happy holidays. Everyone be safe. Enjoy your families. Enjoy your time. And we'll see you next year. Thanks for joining us.
Bye, everyone.